Welcome to this structured summary on analgesia in the ICU, covering pain assessment and management strategies. Despite routine care, pain remains a major issue for patients in the intensive care unit. A high prevalence of patients, 50% who leave the ICU, recall pain as their worst experience. We must also address opiophobia, which often leads to inadequate pain control. It's important to know that opioid use in hospitalized patients for pain relief does not cause drug addiction. Next, let's review the key methods for pain assessment and monitoring in the ICU. Pain is subjective, defined by intensity, duration, location, and quality. Intensity is the primary parameter we monitor. For conscious patients, direct communication is the best approach, using tools like the numerical ranking scale or visual analog scale. The goal is a score of 3 or less. For unconscious or sedated patients who cannot communicate, the behavioral pain scale is the appropriate assessment tool. With assessment complete, we now move to non-pharmacologic and pharmacologic management strategies. Before or alongside medication, manage physical stressors. This includes proper patient positioning, adjusting ventilator tubing, and stabilizing any existing fractures. Opioids remain the mainstay of therapy for pain relief and mild sedation in the ICU. Opioids stimulate CNS receptors to provide analgesia, sedation, and pupillary constriction. They are most effective for dull pain, but less so for neuropathic pain. Doses must be titrated to the patient's individual response. Continuous infusion or scheduled doses are preferred over intermittent, as-needed administration to ensure adequate control. Common delivery methods include intravenous administration with agents like morphine and fentanyl, and patient-controlled analgesia, which allows patients to self-administer small boluses. Epidural analgesia is popular for thoracic and abdominal surgery, producing band-like analgesia. It's often combined with local anesthetics for a synergistic, opioid-sparing effect. For non-opioid options, ketorolac is a common parenteral NSAID. Ketorolac is 350 times more potent than aspirin. It's effective for post-operative pain and reduces opioid requirements by 25 to 50% without causing sedation or respiratory depression. Dosing varies based on age and renal function, but the duration should not exceed 5 days. It is contraindicated in patients with a high risk of bleeding or pre-existing renal impairment. Finally, let's quickly cover the adverse effects profile of these analgesics. Key adverse effects include dose-dependent respiratory depression and cardiovascular effects like hypotension and bradycardia, which are usually mild but can be pronounced in hypovolemic patients. Other common effects are gastrointestinal issues like nausea and vomiting, and urinary retention and constipation, which are common with both systemic and epidural opioids. Thank you for reviewing this lecture summary on analgesia in the ICU. Effective pain management is crucial for patient recovery.